insisting on medical graduates on signing some kind of bond to serve for a number of years before they can ever think of immigrating. How does that sound to you?
I cannot clearly say how that proposition, fared, but if you have taken the time to look at the document I've been referring to, the document on medical national policy on health workforce migration.
All right, you are welcome once again to Conversations, coming to you from Kaftan TV, the Abuja studio. And I'm sure that you're used to a particular face whenever conversation is mentioned. But today, whatever it is, I'm here to stand in for the regular person, and my name is Dayo Omoogun. I do hope that you will still have the same beautiful program, the same very educative, enlightening, informative, and some plays here and there, some humor here and there in the mix. And so you'll have a well put together meal at the end of this show. Once again, like I said, my name is Dayo Omoogun, and I have a guest with me. His name is Dr. Tochukwu Nnamoko.
Yeah.
He's not a PhD doctor. He's a medical doctor, and you know what that means. He will tell us a lot more about himself right away. You're welcome.
Yeah, thank you very much, viewers. My name is Dr. Tochukwu Nnamoko. I'm a medical doctor trained at University of Nigeria, Nsukka. I'm also a member of the West African College of Surgeons. Yes, that's basically that about me.
All right, okay. Let's take it a little bit further, talking about you. Maybe tell us a little bit of your parentage, a little bit of your growing up and all that.
Okay. Well, I'm the second in a family of 9. My dad and my both parents are business people, and we have different educations, as the case may be. I'm the only doctor in my family. Yes.
Yeah. So yes. You're like the family doctor.
I'm like the family doctor.
All right. So we're talking about like how many aeons ago, how many decades ago have you been around?
Oh yes. I'm currently 43.
All right. Okay.
43 years.
And it will be nice to hear the name of the wonderful parents who sired you, who brought you.
Okay, my father's name is Mr. Godwin Nnamoko, and my mom is Mrs. Veronica Nnamoko.
All right then. Yes. And from which states is this?
My father is from Enugu State in Kano West, Abugo, while my mom is from Abacha, in Idemili North of Anambra State.
Anambra State.
Yes.
Whatever it is, both of them are from the southeast.
Yes.
All right. Okay, so you're welcome, Dr. Nnamoko.
Yes.
Did I get that right?
Yeah, you got it right.
What does that mean?
Well, it means that my father is
because
a
I
brave
know
man.
Nna.
Yes.
Nna
My
is...
father is a brave man.
Right.
Yes.
He's a great man.
He's a brave man.
Brave man.
Yes.
Oh, really? Did he catch some lions?
Yeah. No, they were great hunters back in the years.
So
yes,
you know.
They were great hunters back in the years. Yeah. So it's a trivial name, and all that, but we have sustained it over the years.
Right. Okay.
Yes.
Great one.
Yes.
Okay. So he comes from a line of the brave, and no wonder he took on the brave decision to become a medical doctor.
Yes.
How has it been this many years?
It's been an exciting journey, and back in those years, once you're a bright kid, your father would say, "Oh, this guy
Must
has
become
a
a
brain
doctor.
for a doctor," and all that. And it was the prestige that comes with the medical profession and all that, and the fact that we have the opportunity to impact and change lives, and all that. So that was the motivation that we had growing up, and of course I went to medical school, finished. I was also trained as a gynecologist.
All right.
Yes, and became a member of the West African College of Surgeons. But I almost say that I quit active medical practice about 6 years ago.
Oh, okay.
Yes, it has. So I delved into a total different field. Currently, I run a company called Tiibilon Construction, with interest in medical infrastructure. Yes, and that's basically where I'm currently.
Okay. Yes. Okay. So we will go into the medical area right now, and first of all, there's a prevalence of all kinds of diseases as we speak right now, all kinds of challenges, medical challenges, and people are spending a whole lot of money to keep their body in good shape, and this is not very convenient for most Nigerians considering the economy. Now, we have seen cases. You are a gynecologist, and we have seen cases, plenty cases. It looks as if the cases of infertility or delayed fertility or whatever it is called is growing in the population, and it looks as if it never really used to be so. What are there factors that could be responsible for this?
Yes, well, I think one of the key component of infertility. Well, if you're going to discuss the issue of infertility, you must clearly define it in the right perspective.
Okay.
Infertility has a both male and a female component of infertility.
Right.
Yes. If we look at it in that perspective, then we would look at common factors that are responsible for the increased incidence of infertility in our environment. One of the common factors is delayed attempt to procreate. Women chasing careers and all that.
Okay.
So back in those days, where our parents get married early, 20s and all that. The longer it takes for a woman to attempt, to get married, the more it is. Of course, also other factors that I can say that increase in infidelity. Because a lot of conditions that cause infections like epidemic inflammatory disease and all those things, all those conditions that are linked to increased sexual promiscuity.
Right.
Yeah. So they are the one key component that we can say are responsible to that. Other common trends are exposure to radiations. With all kind of technology and
gadgets
all yes.
And everything.
So we can attribute this as a component of infertility, because the exposure to radiations can affect even the male genitals and all that, and can give rise to it. But that is me discussing infertility as and narrowing down to common reasons why they But if we're going to do a proper infertility workup, then we'll be looking at trying to track causes, from the uterus, possible things, each history of a previous termination of pregnancies, that can make a woman like what we call Asherman syndrome, a syndrome whereby the anterior and the posterior walls of the uterus, are closed up, so it's difficult for any activity to operate there.
Right.
Yes. So it's a whole lot to discuss. But I'm just trying to keep it very basic,
very,
as possible.
very short. Yes. Yeah. Of course, for a program of just 1 hour, we can't go into too much details.
We'll also look at the male factors, look at seminal analysis, and look at the possible causes. There are genetic factors too, that can be responsible to that, and all that. So quite a lot of things that we cannot exhaust in this short time. Yes.
On this show. Yeah, but we also have, from what we read on social media and in main media, we hear that there are a whole lot of things that happen to people that are traceable to their lifestyle.
Yeah.
And some of it is that people hardly exercise. Let's talk about this. What are the lifestyle practices that tend to promote the kind of challenges that we see that are prevalent in society today? I just read in the newspapers this morning that there are cases, the cases of kidney disease are on the rise. And some of the patients were lamenting that they spend as much as 150,000 naira per week for dialysis. That's huge.
Yeah,
and so talking about the kidney, talking about the liver, talking about what are the lifestyle practices that tend to position people for such challenges?
Yeah. Okay. I think the common ones are, one, lack of exercise, as you mentioned. Because lack of exercise, it's responsible for quite a lot of things. One key component that we can talk about is smoking. Smoking has been linked to a lot of conditions, from lung cancers to different other kind of cancers, and all that. So the other lifestyle changes that can adversely affect a human life. It's alcoholism. Alcoholism is connected with all kind of conditions, from alcohol liver disease, to alcohol fetal syndromes and all that, and all that. So I think, then they also mentioned technology, these are phones, like close proximity to these phone radiations, they have been linked to quite a number of cancers and conditions, and all that. So there's a variety of them. But I want to specifically mention about exercise. The truth is that exercising can cut down quite a lot of diseases, from diabetes mellitus, to hypertension and all that. Yeah. So these are the common ones that we'll talk about. Then even our life-work balance. Life-work balance. The truth is that we also have to find a way to strike this balance, because one of the commonest causes of hypertension is stress. In fact, the type 1 hypertension, which we call the essential hypertension, is linked to stress. So we must ensure life work balance, because these are lifestyle changes that has contributed to significant disease condition, as the case may be. But most of the kidney conditions you're talking about are linked to these conditions I've mentioned. For example, if you're talking about causes of kidney conditions, we're talking about conditions linking to diabetes mellitus, Okay. Yes, or kidney conditions that are linked to hypertension. We call it hypertensive kidney disease, or diabetic kidney disease.
Okay, so
yes.
So it's kidney disease is usually provoked either by hypertension or provoked by diabetes.
There are a variety of causes.
Okay, but these are major ones.
There are a variety of causes. There's also HIV induced kidney diseases. Sickle cells induced kidney diseases.
Yeah.
You understand? Beyond the other body hemostatic balances that can cause kidney problems.
Right.
So, but I'm just trying to connect lifestyle changes that can be connected with kidney disease or every other health conditions.
All right.
Yes.
So when you talk about life-work balance, what exactly do you mean?
Yeah. Now,
there's somebody listening out there who's saying, what does that mean?
In the context of health, okay, in the context of health, there should be a conscious effort for we not to expand ourselves to the point whereby we're distressed. Because the truth is that hypertension is one common condition that, expanding yourself without taking a break, occasionally can lead to stress that can lead to hypertension. So probably I'm talking about that life work balance, whereby you should know when to expand yourself and always when to recoil and rest. Yes.
Right.
Yes.
Right. Okay. So remember, dear viewer, there's a time to recoil and rest.
Yes.
You must develop life-work balance. Okay, so Dr. Tochukwu, let's talk about something that's been in the media space, in the public domain for quite some time, and it's become quite worrisome both to individuals and even at the government level.
Yes.
It's called the Japa syndrome.
Yes.
I'm sure you know what the Japa syndrome means. You find a situation where the Japa syndrome, where professionals and particularly medical practitioners leave the shores of Nigeria to go practice elsewhere. And first, we need to know what are the motivating factors. Why is this such a huge problem? Why is it's increasing? So why can't we retain our doctors? And if we have spent so much to train them, why should we lose them? Why should they not have? Okay, maybe let's take them one after the other. Yeah.
Okay. Would you mind I give an insight on the degree of challenges we are facing in that direction if I talk about the reasons why?
Yeah.
Yes,
why not?
Yes. Now, I think I'll just read out some statistics,
right,
so that we can appreciate the measure, the problems we're dealing with in the the healthcare sector as regards the Japa syndrome.
Right.
Okay, yeah. Now, the Medical and Dental Council of Nigeria was established in 1963. And between 1963 and today, Nigeria has produced a total of about 130,000 doctors.
Okay.
Okay. Now, both dead and alive.
All right.
Okay.
Both dead and alive.
Both dead and alive. Now, in 2023, the stats we have for 2023 as regards doctors who have renewed their licenses is just about 45% of this number, which is about 58,000 doctors.
Right.
So currently, we can say that Nigeria currently has about 58,000 doctors, MDCN figures. Okay.
Right.
Now, if you look at between 2010 and 2016, Nigeria was losing an average of 600 doctors every year. Yes. Now, that number increased between 2019 and 2024 to about 3,200 doctors every year.
Wow.
Yes.
About 5 times.
Yes, 5 times. In fact, one of the documents quoted by that was quoted that the Ministry of Health was quoted. You mentioned about 16,000 doctors in this timeline, which is about 3,200 doctors within that timeline. Now, if we look at the WHO recommendation as regards the ratio of doctors to patients, it's about 1 to 1,000. Like, for you to have adequate healthcare services, we expect that you should have a minimum of 1 to 1,000 doctors, one doctor to 1,000 patients.
Yeah.
Now, if you look at if we look at the figures we currently have, what it means is that Nigeria currently has 1 doctor to about 5,000 patients. That's the stats that we have. The impact is this: if we take common medical indices like maternal mortality ratio, these are the common indices I'm sure you're familiar with. Nigeria currently has the 3rd worst figures in the whole world. Currently, just following South Sudan with their wars and Chad.
Imagine.
So, yes, that is
those are countries at war.
Yes, over 1,000 patients die in 100,000 live births. So that is actually the magnitude of the issues we are dealing currently with. And I took my time to also look at, Nigeria has about 26 centers that produces doctors, that centers that had accreditation to produce doctors, 26 of them. They are currently producing about 2,300 doctors every year. And if you look at the stats I gave, we're producing 2,300 doctors and we're losing 3,200 doctors. So we see that there's a big deficit between the number of doctors Nigeria is producing yearly and the number of doctors that we are letting go or are leaving this country. What are the common causes? The fact is, the major cause of it is economic factor.
Right.
Yeah, economic factor. There's a big disparity between doctors earning in Nigeria and what doctors earn in places like UK, like Essex, these big disparities, or what doctors earn in the US to most extent. You understand? Yes. So just like every other sector, the truth is people are always going to migrate from a place of lower economic status to a place of higher economic status. Yeah. Other factors are insecurity, kidnappings here and there, infrastructure that are not very adequate, training infrastructure and all that. So, but honestly, the key factor, if you look at the stats I just gave out, between 2010 and 2016, it was 600 per year. Yeah. With the recent naira devaluation and all these factors that has happened in the last with the COVID-19 naira devaluation and all these factors that made the exchange rate to widen the way it did, more doctors left because there's a marked difference between the rates doctors earn in these countries where they're going to and what they earn in Nigeria.
Is that in real terms, or is because of this foreign exchange thing? For example, does it really translate? I mean, what they earn, does it really translate to a much better life than what they could get at home?
Well, the fact is, the fact is,
I'm talking about the purchasing power over there of their own currency, and compared to ours. Are you saying it's a world of difference?
No. The way I look at it is this, okay? The way I look at it is this: is that even if you can save $1,000, okay, currently that is you're able to save 1.5 million naira, And that's what it is. So it, of course, it's automatically amounts to better quality of life and all that. They can have way more to send back to their families in Nigeria, and all that. So that is the fact is that you cannot remove the economic components in the cause of this Japa syndrome we've been discussing today.
And it has also been said that working conditions also are a major part.
Yes,
like having the right equipment
to work
and all
with.
That to work with.
Yes.
So how much of that?
Yeah, it can be it can be really bad. Yeah, because I know there's some primary healthcare centers in some states where doctors has to use torchlights to conduct deliveries, surgeries and all that, But the truth is this government has done a lot, doing a lot, to different state government, a lot of intervention ongoing. I can assure you, because we also have to acknowledge the effort the government is making so far. That's a fact, Like I know my state, for example. My state governor is currently building 260 primary healthcare centers in the state, and quite a number of state governors at the federal level trying to equip and replace equipment and all that. All ongoing, here. But that's why I'm saying one of the key components is this whole economic factor. Yes.
Now, how does it? You have heard about racism.
Yes.
And all that. When you put that into the mix, into the equation, would somebody not rather be at home and be proud, be at home and be sure of not being ill-treated on the grounds of race than to go somewhere else where you earn a little bit more? Or maybe it's not a little bit more, where you earn a lot more, and but you're treated like second rate.
Yes. No, the truth is quite a lot of doctors in Nigeria and generally abroad do not like the fact they are there. About the fact, it's a fact, and that is why I strongly believe that with all we need to just do collectively, both the government and private sector, initiatives like we are trying to do, is just to bring a little tweak to the whole thing. Racism is a stack. There is racism globally, and a lot of doctors, a lot of Nigerians generally, both doctors, health workers, nurses, they face this racism.
Right.
But if you look at the disparity between this pay, yes, people will not deal with. So it's now a situation of choosing between two wrong things. You are choosing between two inappropriate things. You have to deal with the more pay
between the devil
and the DWC. Yes, that's basically how it is. So, and that's why I strongly believe that if a little more is done, it will be easy to bring a lot of doctors back. I interact with my friends globally, doctors everywhere, and I can assure you that most doctors abroad, most Nigerians abroad in general, want to come back if they have maybe just a better opportunity here back in Nigeria. Yes.
So, so you're saying that there are a number of things we could do that could reverse the Japa narrative, right? You think so?
Yes. Now, of course, that brings us the solutions.
Yes, that's
the solution now. Yes. First, I want to acknowledge what the government is already doing currently. Okay, yes. I've mentioned earlier, some state governments are building more infrastructures, primary to secondary, equipping of different healthcare centers and replacing equipment that have gone moribund and all that. And I also specifically discuss current government. There's this particular the national policy on health workforce migration. It's a committee set up by the Federal Ministry of Health under this current government. And they have sat down to articulate these issues in this medical health workers migration. And they have talked about ways more to incentivize doctors to stay. So they talked about things like a provision of loans to private hospital constructions, try to see how they can review salary scales and provide infrastructure. So these are what the government currently is doing. Now, but there's something that we as a foundation, now we are a foundation, what we're trying to do is to run a campaign on what we call med-entrepreneurship. It's born from the conventional conversation as regards every sector being changed or being changed by private sector-driven initiatives. The sector, we believe that what will change the narrative in the healthcare sector is driving the med-entrepreneurship program. And the whole idea is the fact that is to train more doctors in hospital management, or the business around the healthcare sector, So we can have not just having doctors who are trained to look for job in hospitals and all that. Doctors who are business oriented, who are thinking of how to create a business, set up systems that are sustainable,
and then become employers,
and become employer of labor themselves. So we're talking about med entrepreneurship, And the truth is, if you look at, we also study different countries like India, they are big on med entrepreneurship. There's this hospital called Apollo Hospital in India. They have built close to about 73 hospitals, just a private initiative. They have built about 73 hospitals all around India, and a lot of Nigerians are going, to those facilities to seek healthcare. So we're talking about med entrepreneurship as one key component of it. Another very interesting.
Let's take that other one after a break.
Okay, yes.
Let's take a break.
Yeah.
All right. We're back on Conversations, and today on this edition we have Dr. Tochukwu Nnamoko, right?
Yeah, thank you very much. Yeah, that's my name. You got it right this time.
Right. I got it.
You got it right. You got it right. Yes.
Okay, good. So we've been talking about the medical landscape in Nigeria, and we'll be talking about something that's very dear to the heart of millions of Nigerians, the Japa syndrome, how to reverse it. And that's what he's talking about, trying to proffer solutions. And he's been talking about payment, salaries, salary increment, and then he's talking about medi-entrepreneurship. Is that it?
Medi-entrepreneurship, yes.
Okay. Tell us more.
Medipreneurship.
Yeah.
Medipreneurship.
Medipreneurship. Tell us more.
Yeah, basically it's about driving more doctors' interest in the medical businesses. Understand that and it's born from their understanding that every system, every sector is developed by a private sector driven initiative. Yes. And so we're trying to run campaigns on awarenesses, getting more doctors to be trained in hospital management, hospital business management, and all that. Then I also want to specifically under this med-entrepreneurship, there is a hybrid of entrepreneurship that I want to talk about, and which is what we have called the hospital co-ownership business model. Okay. Yes, and what it simply entails basically is to get doctors in clusters, maybe 10, 20 doctors in clusters. Provide them with platforms or facilities to be able to co-own hospitals. So you have a hospital owned by 20 different doctors. Maybe they own like the consulting rooms in the hospitals and all that, and also have other investors, invest in a particular mega hospitals and all that. And it can be cut across both primary, secondary, and tertiary healthcare centers. The principle is simple. The principle is this: one, if we can get these doctors to get this kind of facilities, single-digit loans and long-term loans. The whole idea is this: if you provide somebody with a doctor with a 15, 20-year loan, that automatically is keeping him back in Nigeria. So we are introducing what is called the run to own. They run to own the hospitals. Now, because we're trying to do, and this particular model is doing two things. One, it is providing more medical infrastructures in Nigeria, one. And number two, it's also keeping doctors back in Nigeria. And in our campaign on this med-entrepreneurship and hospital co-ownership model, I've been talking with doctors all over the world, in US, in Canada, as the case may be, and a lot of doctors are interested because to set up a hospital is actually very capital intensive. Yes. Yeah. So, but what we're trying to do is to create a medical ecosystem whereby doctors can partake in this ownership. They won't have to worry about managing of the facility because of that very major component. I can tell you a lot of private hospitals in Nigeria are struggling to keep afloat because of the task of having to manage the hospital facilities. So we have a system whereby we're being an ecosystem whereby the hospitals are not being managed by the doctors. They have to worry about the lighting, the this and all that. That's actually a facility management company that manages that. So they have to just focus on their medical craft and all that. The advantage is one is that it's going to give the doctors in Nigeria. That is one. Number two, it's going to spur reverse Japa. It's going to reverse Japa. Number three, it's going to make Nigeria a medical tourist center. Because you see doctors coming from all over the world, setting up mega centers, bringing all kind of expertise and all that. And I can tell you, we can be a Japa, a medical tourist center in the whole of West Africa. So that's basically what we're talking about. We're talking about medi-entrepreneurship. We're talking about the hospital ownership model. And also, I want to also mention that the healthcare is not cheap. Yes. And if you're talking about private sector-driven healthcare revolution, we must also be talking about a valid and robust national health insurance scheme. Yes, because the truth is that Nigeria currently has one of the lowest health insurance coverages in the world. It's about 35% of Nigerians have any form of medical health insurance. Sure. Yes.
Now, looking at the fact that almost everything that gets privatized in Nigeria goes very, very expensive and out of the reach of the ordinary Nigerian. Yes. And looking at what you have just said, are we not going to a point where healthcare will be priced out of the reach of the common man?
Okay, yes.
Because every business sets out to make profit, isn't it?
Yes.
And so if a larger section of the health sector is in the hands of private practitioners who intend to make profit, how does that sit with the public need for health services that are affordable?
Now, we can argue about this for all day. The truth is that most of these nations, these countries that Nigerians run to, they run to, healthcare is not cheap anywhere in the world. If you ever hear, if you've ever said healthcare anywhere in the world, it's not cheap. Right. And that's why I mentioned earlier, there must be a robust, widespread national health insurance scheme. And that is how, if you're going to the UK or anywhere, it's sacrosanct. Like, even you as a visitor, it's sacrosanct that you have to key into, a health insurance scheme if you're going to have any health. So yes, health is not cheap. And if we're going to be serious about a healthcare sector, then we must also agree that it has to be funded the way it should be funded. So your question is simple. One, there must be private sector participation, active private sector participation in the healthcare industry. Then we'll talk about policy changes in the health insurance scheme, trying to run campaigns on broadening the insurance nets, and having as much as possible, way more people who can access healthcare via the health insurance scheme.
So the health insurance scheme will take care of the needs of those who are of the lower echelon.
That because the structure we have currently will have to be improved on. Because there might be policies to modify and improve the quality of services or the structure that the health insurance scheme currently has in Nigeria. The whole idea is to ensure we broaden the drag nets and have way more people. Because currently, just about 5% of Nigerians currently are on any form of health insurance coverage. Yes. It is really, really low. So it's for us to have run more, and that's what we're trying to do with our foundation, trying to see how we can increase, run campaigns awareness in the health insurance coverage in Nigeria. Also to talk about, because there's a complaint about the quality of services we get in health insurance and all that. But there's also that one side of the story where we're talking about capitations and all that. These are the things that have to be looked at and see how we can review the terms currently, how make it more attractive for people to key into, and have more people to be come under the umbrella of the health insurance scheme. Yes.
All right. Now, what's the name of this foundation, by the way?
Yeah, we call Tiibilon Healthcare Foundation.
Tiibilon
Healthcare Foundation.
Is that billion?
It's billion.
Oh, billion.
Yeah, it sounds like billion.
Exactly.
But
I needed to clarify that.
It's
so it's spelled without an I after the L.
Yes, Tiibilon, yes.
Okay.
Yes.
So Tiibilon.
Tiibilon Healthcare Foundation.
Is that T on its own or
T-I with apostrophe billion?
All right. Okay.
Yeah.
Okay.
Healthcare Foundation. Yes.
Tiibilon Healthcare Foundation.
Yes.
And so, you operate that locally in Nigeria?
Yeah, locally in Nigeria for now, yes.
So you're one of the patriotic doctors who has refused to Japa, is it?
I feel like the Moses in the healthcare sector right now. Yeah, I feel like the Moses in the healthcare sector, yeah, because honestly, the truth is that our current health status in Nigeria is not sustainable. The rate at which doctors are leaving this country. And also, the health workers, nurses, pharmacists, almost every health worker in Nigeria is writing one exam.
Oh, the other.
Yeah, that's how bad it is. Even the ones who are in Nigeria currently are either writing one exam or have attempted to write one exam and
preparatory
or maybe they are yet to maybe pass one exam or the other. You understand? That's the magnet. It's not sustainable. It's not sustainable. And the truth is that, be you big and small, politician or not, the truth is that when you have health challenges, we all come back to one square. And that's a fact, yes. So it's not about who is big or who is not and all that. It's about tackling this issue that affects us all, in unison, and trying to find a solution to it. And the truth, and health in Nigeria can be a major contribution of our GDP in Nigeria. Yes. So these are the things that we're trying to push for more medipreneurship, bring campaigns. It's going to be a major contributor to our GDP in Nigeria if these initiatives are fully optimized.
Yeah. So are you expecting, is there a place for government to key in on this? Are there government approvals that you require or whatever? I mean,
yeah, primarily, honestly, one of the key ways we're looking at is we as private sector, we can always ready for the financing for the hospital development and all that.
Yeah.
But one of the key ways that we think government can participate is we can have what we call national hospital fund or whatever, despite the fact that under the policy document that has been released by the Ministry of Health, they talked about providing loans for doctors to own hospitals. So what I'm looking at is that we're looking at a situation whereby doctors will have, just where we have national housing fund, yes, that enables developers to be able to provide housing, and the people can pay over as long as 30 years, the case may be, yes. So that's the key areas we're looking at. Giving those doctors incentives, single-digit loans, and long-term loan. Long-term particularly because that will be doing two things. One, helping the infrastructure system to be upgraded by enabling doctors to participate in the ownership of a hospital, and primarily tackling the Japa syndrome. Because if you're giving somebody a 20-year loan, you know what that means?
He has
to stay to run.
Yes.
Yeah, you have to stay to run. So that's basically what we're looking at. So those are the areas that we are looking. We're also looking at collaborations, in policies. We're looking at policies where areas like a health insurance scheme, looking at where, how we can make the health insurance scheme more robust, more efficient, so that we have way more people that will come under the health insurance dragnet.
Thus far, how has it been?
Yeah, well, it's been exciting for me. I just feel accomplished, Yeah, I feel it's been intriguing. We have been taking our campaign to different people, different places, cost visits, going to different people, stakeholders at different tiers, talking to them about the issue which everybody has. We all accept is a glaring issue that everybody is facing. Yes, and we're also looking at doing more and all that, because our company, our company, Tiibilon Construction, also we're partnering in partnership with our construction company to churn out the first tier of that kind of project by end of this year.
All right.
Yes.
Has a presence around the entire country?
So currently, primarily we're in Abuja currently, alone. Currently, yes. We're looking at branching into Lagos and other states, yes. But currently we're in Abuja, primarily in Abuja currently.
And are people buying into this idea?
Yeah. So what we first did was to conduct a survey. We conducted a survey of a couple of doctors, local, international. We started surveys to get people's brains. And as the case, primarily health workers, because what we're trying to do is not just for doctors alone. Because we're trying to build a full medical ecosystem, whereby pharmacists can co-own laboratory, so a full ecosystem. So just imagine a plaza that has every single thing, but owned by different individuals, but it's under an umbrella, healthcare umbrella. So, but the doctors and the health workers will form a quorum. We form a quorum that will be in the board. They'll register it as a hospital, but they're going to run independently. Their medical crafts is fully expressed, determine their economic outcome, and they have the potential to scale, and all that. I know it brings me back to the commercial where you compare financial freedom and more pay. The truth is that people always prefer to have control over their lives and their financial outcome. Yes,
definitely.
Yeah, that's basically. So, but yeah, a lot of people are big on it, and I can assure you, there are a lot of doctors who are trying to come back to Nigeria. And there are quite a lot of them. There is a particular place in Lagos, it's a cancer center owned by some Nigerian who has worked about over 30 years in the UK. Currently she owns this amazing healthcare this cancer center in Lagos and has been attracting patients all over the world. So yeah, there's a lot of doctors that want to come back to Nigeria. But you know how it is. They won't want to come back and own a shabby health facility. They want to come back to something more systematic, something more structured, and all that. And so this is what we're trying to see how we can provide this kind of platform whereby they don't have to break their backs or take a loan that is back-breaking, to own a hospital. Provide that kind of a medical ecosystem where they can plug in, provide the medical services and all that, and use technology, telemedicine, and all that to operate. So that's basically kind of the kind of medical future we're looking at in Nigeria. Yes.
All right. So thus far, from your experience, both as when you were practicing and now that you're into this foundation program and all that, what would you consider as the most formidable challenge that the medical industry is having to contend with?
Well, I think primarily, if I say the medical industry generally, the key factor, what I would say, medical infrastructure. If you're looking at how the perception of the Nigerian population to the medical, the healthcare sector, we'll talk about medical infrastructures and all that, but also the medical personnel availability is also a major component.
Is that linked to the Japa thing?
Yeah, that is what we're talking about. Medical, because we're talking about a huge deficit. Nigeria should,
personnel.
Every functional system should have an average of 1 doctor to 1,000 patients.
Today you have
and we're doing 1 to 5,000 patients. Yes, that's it. So of course we know what that means. What that means, there will be pressure on a few ones are available.
Yes.
There will be unavailability of doctors in remote areas.
Sure.
Because the way it is going right now, doctors are mainly in places like cities like Abuja, Lagos, Port Harcourt, and all those kind of places. But if you shock you that there are very or no doctors in these remote areas. And what happens when there's a vacuum? What happens when there's a vacuum? Quacks. Quacks filling these vacuums. I think as I was coming to this show this morning, a friend of mine was calling me and said how she went to a pharmacist, from a patent medicine shop, and the guy who she met there did not even know the drugs that they were on the counter, again, and that's how bad it is, because what happens is that quacks are taking over the industry in those remote areas. They shock you how people who have no form of medical training are operating on patients, doing all kind of surgeries, and all that. So this is what happens when there's a vacuum, because people have to survive, people have to survive. So you find that quacks will take over the vacuum that is created by this non-availability of healthcare professionals in different sectors. And that will, of course, will amount to more mortalities, more death, poor services, and all the case may be, yes.
All right.
Yes.
Maybe we'll take a break and then we'll take 1 or 2 questions before that. All right. Welcome back. We're still on conversations. And right now, we will be winding down a few minutes from now. I've been talking with Dr. Tochukwu Nnamoko.
Yes.
And he's been telling us about some of the solutions that we can apply to changing the Japa narrative. And they have also found one. They have tried to provide one solution, which is the Meditrust
Medi-entrepreneurship.
And then also they have a foundation to run this. And it's saying that Nigerians are into it big time. And so as we begin to wind up, what exactly should government be doing at a time like this to further shrink the number of people who are Japa determinant, who are determined to be on the run? Okay, what should be done? That's for people who are still here to sort of prevent them from going.
Yeah, I would commend the government currently, because there's a full document on health workers' policy on migration, and they are starting to articulate the problems, and all that, and provide solutions. Some of them they're talking about incentives for doctors, which incorporates allowances, reviews of salaries, as the case may be. They're also talking about articulating the migration program to have like a detailed, documented, migration program, You know, in that document, they also mentioned the issue of providing loans to doctors who want to have private hospitals, as the case may be. So quite a number of things that doctors are currently doing on that. Also, the other issues that most doctors have raised as the causes of the migration, Japa syndrome, is insecurity.
Right.
You know, they're more aware. We're also enjoying efforts already being made. We can all attest the fact that we don't have that measure of kidnap rates as it used to be years on hand. But we also want to commend the government to do for what they are already doing currently, and also hope that more is done to curb the insecurity in that case. Because I think there was 2 years ago or 3 years ago, I think there was a whole state strike. Just because, yes, a doctor was kidnapped in a state, you know, and all that. Yeah. You know, so these are so insecurity is actually a major issue that has been a contributor to. So I think government should do more. Kudos to what they're already doing, but we also hope that, you know, we do more and all that to curb the insecurity issues. On the infrastructure, hospitals, more hospital funding, you know, hospital equipment, you know, provision of upgrades from primary, secondary to tertiary centers. Something like, I think Gombe State recently upgraded their government general hospital to a teaching hospital. So these are all the kind of measures that the government can do, which require equipping of more hospitals, as the case may be, in another. Then training, because the truth is that just like every sector, everybody wants to improve in his or herself. One of the key reasons why people migrate also is that belief that you have better healthcare training services, you know, and all that. So because the truth is that there are contemporary equipment everywhere, here and there in the world, you know, whereby if you call yourself a gynecologist or you call yourself a surgeon, you know, you expect that some certain kind of, you know, modern technological equipment you should be exposed to. So we're also enjoying that more of these equipments to be available for training of doctors. So we have more refined, more specialties, you know, in the healthcare sector. So these are the 4 common ones that I want to mention. Yes,
it's been reported that government is also considering the option of insisting on medical graduates on signing some kind of bond to serve for a number of years before they can ever think of immigrating. Yes. How does that sound to you?
I cannot clearly say how that proposition, you know, fared, you know, but if you are taking the time to look at the document I've been referring to, the document on medical national policy on health workforce migration, you know, one of the things that it was a beautiful document. I think you can look at it. It's a beautiful document. And one of the things that they factored was striking a balance between the basic human rights that allows freedom of migration, you know, with managing the issue of the Japa syndrome. You know, so it was clear that the government acknowledged the fact that people has the rights of migration, which is a common basic human rights. You know, because that was the debate that spurred up from that conversation. You know, debate of how much of these human rights are going to be infringed on if we insist that, you cannot leave Nigeria and go somewhere else because, you know, you train in Nigeria and all that. So, but I'm not very clear how that spawned up. I know there was a proposition to that, but what I don't know is if the policies currently have been stable. I know that document specifically talked about acknowledging the fact that people had the right to migrate, but they found how to incentivize people, try to improve the services, which is actually the way it should be. Improve the services, try to find how to address the issues, you know, on ground, and hoping that with these measures to be put in place, more people will come back to Nigeria. The truth is that, let me just tell you, there's a lot that we can gain as a country if we take care of this issue. Currently, Nigeria has about in the US alone has over almost 4,000 doctors in the US alone, and it's a huge human capital.
Now, just before we go, in case there are doctors who are interested in what you offer, I mean, what do you call it again?
Medipreneurship.
Medipreneurship.
It's coming from the word entrepreneurship.
Okay, like mediapreneurship and all.
Not medical.
No, I'm talking about mediapreneurship.
Yes, like that.
So, as final word, how would they be able to latch onto you? How would they be able to reach you?
Provide our emails, addresses, and all that, you know, on phone numbers. People can contact us, our phone numbers, email addresses, and all that. Can contact us, so we can explain further.
Maybe you should so let's have the email addresses. Somebody could just be listening and want to take it up from there.
Okay, yeah. My email address is Tochukwu, TOCHUKWUNNAMOKO @tiibilon.com, TIBILON, or Tochukwu Nnamoko @gmail.com.
All right, just give a number.
My phone number is 081-6868-9700.
Ladies and gentlemen, that's going to be the size of conversation today. My name is Dayo Omoogun, and I've been talking with Dr. Tochukwu Nnamoko. I do hope that you had a great time watching this edition. Bye for now.
Thank you very much, viewers.